and welcome to this presentation on patient safety. I'm Carmel, and I'm going to use Professor Charles Vincent's book on patient safety as the main basis for this presentation, and work done through the Health Foundation Inspiring Improvement. And the title of this is Essentials of Patient Safety, and there's an accompanying reading material that goes with this, which I would strongly encourage you to review in detail. We'll start with discussing a little bit about defining the issue of harm and error. It's worth reviewing the actual scale of the problem, both from the adult and paediatric literature, and then build an understanding of how things go wrong, with moving on to how improving safety through two different approaches, healthcare systems and processes, and standardizing them, for example, and looking really at how people create safety. And importantly, I want to also discuss what happens after an incident, because sometimes I think this is a bit neglected. So it's sometimes a bit tricky thing. What does an error mean? I think firstly it means that whatever's happened was not really desired by either a set of rules or if an external observer was watching. So something about not being desired. And that some form of action has led either the task or the system to be outside of acceptable limits. So that suggests that there's some kind of failure or performance shortfall. And that thirdly, that this wasn't intended, but at least must have potentially been able to act in a different way as well. And really, all three of these criteria can be challenged, or at least difficult to pin down in practice, because of course a lot of our clinical practice is inherently uncertain, and there are frequently, for example, no guidelines or protocols to guide treatment. And additionally, actually deciding that failure has happened isn't easy always to identify. It is certainly not always clear, at least at the time that it's happened. So, for example, when a diagnosis is wrong, or when, at what point blood levels of a drug became dangerously high, this may not be realized till much later. And then finally, the notion of intention. So in theory, you have to at least be able to act differently if this point has been violated. And we can challenge that notion, because people's behaviour is often influenced by factors such as fatigue and pressure, and really they may not actually be aware of or have little control over these factors. And I think that's where the understanding of human factors and biases can actually be very helpful. So it's worth noting that while the definition perhaps sounds reasonable, we certainly should be aware of its limitations and the difficulties of actually applying this in practice. I think it's worth reviewing briefly the 6 dimensions of what we might look at when we think of quality of care. And first and foremost, this includes that care is safe. So that's avoiding injuries and harm to patients from the care that is intended actually to help them. That it's effective and treating those in whom it's known to be effective, but equally avoiding the treatment in those who it's not likely to be benefit, because all treatments have some form of side effects, so preventing harm that way. That it's patient-centered, and here's a definition. And the importance of this is that, of course, psychological or emotional harm can come of care that's not patient-centred. That it's timely because we must avoid harmful delays. And lastly, that it's efficient and equitable, because it has to be equitable, so we're avoiding undue harm to the most vulnerable. So once we've kind of thought about error and quality and harm a little bit, I want to move to what the scale of the problem in healthcare may be. And firstly, I want to show this table which summarises the estimated rate of adverse events in hospital adult patients between 1980s and 2000s in various developed countries, you can see here. And we can see that this involves large series of patients, over 90,000, with an adverse average event rate near 10%, which really, if you hadn't ever thought about it, is really quite staggering, that 1 in 10 hospital patients will suffer an adverse event. And, we might think that actually, because we're much more careful, we're much more patient-orientated, we're child-friendly, that this may not apply to us in paediatrics. So here's a table showing the review of hospital notes in 25 district general and children's hospital units in the UK. And first of all, the bottom right-hand figure, which you can see at 14.2%. So that represents the total percentage of patients thought to have experienced harm. And this data is from just under 4,000 patients. So on the bottom left, you can see 3,992 patients. And they were reviewed across all these hospitals between February 2008 and November 2011. And the method that they used was using what they called a trigger tool. So this trigger tool was looking for certain phrases in hospital notes to denote perhaps that potential harm may have been caused, and that if this trigger was present, the notes would be further explored by a senior paediatrician to really decide if harm was actually caused. And in the slide after next, we'll look at some of the triggers that they used. But also, at this point, I just want to highlight the huge variation in the percentage of patients in individual hospitals that were thought to have suffered harm, and that's on the most right-hand column. And you can see it varies really from, there's a 0 and 1% all the way up to 26% in the top row there. The types of harm were categorized as follows under the letters E, F, G, H, I. In particular, I want to just draw to your attention that G is permanent patient harm and H is intervention required to sustain life. And wow, I can see that 4.3% of all the events required intervention to sustain life. That's quite sobering. And here's a table showing the triggers that were used, written on the left-hand column. So what the authors did was analyse whether the trigger was present in the notes, and then also whether harm was noted, and they were able to come up with a positive predictive value, which is the right-hand column. So I've highlighted a few examples just for illustrative purposes, and the first one I want to draw your attention to is if an antiemetic was given, then 8% of the time this predicted that harm had actually occurred. And if the notes said that a nosocomial pneumonia had been detected, then 75% of the time patients had come to some form of harm. And if there's been a readmission, at the bottom you can see there to either HD or ICU, and just over half of the time some form of harm was thought to have occurred. And I think it's worth pausing the video at this point and just reviewing how many patients had these triggers recorded in the notes, which is the second column, the adverse events, the positive triggers column, and how many were actually harmed, and in particular the column G, which is permanent harm, and column H, patients requiring life-sustaining intervention. So I think next it kind of makes sense to move to, how should we think about how these harmful events have occurred. And here's a table which has been called the organisational accident model, and we're familiar, I think, by now with the Swiss cheese model of errors, and you can see there those blue blocks there representing what we know about the Swiss cheese model, in that various different types of events occur which in the end lead to an incident. But probably what's a bit less well known is in the analysis of different types of error, James Reason, who came up with this, also divided them into two broad types: slips and lapses, which are errors of action, and mistakes, which broadly speaking are errors of knowledge or planning, and it's worth just thinking about them in that format. So slips and errors are really errors of action, so you intend to do something but it does not go according to plan. And with mistakes, the actions may go entirely as planned, but the plan itself deviates from an adequate path towards its intended goal. And here the failure lies at a higher level, with the mental processes, for example, involved in the planning of the treatment, or when it comes to formulating our intentions, when it comes to judging or problem solving. And so, for example, if a doctor treats someone with chest pain as if they have myocardial infarction when in fact they don't, then this is a mistake. The intention is clear, but the action corresponds with the intention. But in this particular example, the plan is wrong. James Reason and others have also argued that errors really cannot be understood in isolation, but only in relation to the context in which people are working. And this is what the rest of the chart to the left of those blue bars tries to represent. So in considering how people contribute to accidents, therefore, we have to distinguish between active failures, otherwise known as care delivery problems, and other types of unsafe acts. And these are really, because we know, these are really committed, if you like, by people like us at the sharp end of the system who are actually operating it or working with a patient. So, for example, active failures are wrongly opening the bow door of a ferry, misreading the anaesthetic monitor, and these unsafe acts can and often do have immediate consequences, but other factors further back in the causal chain also can play an important part in the genesis of an accident, and these are then called more latent conditions, as they're often termed, lay. and they often lay the foundations for accident in the sense that they create the conditions in which the care delivery problems, the active failures, occur. And therefore, rather than being the instigators of an accident, the people working tend really to be inheritors of system defects, and their part is usually that of adding the final garnish to a lethal brew whose ingredients have already been cooking. So, it's important to consider these wider influences of the healthcare systems, but that doesn't simply mean that you blame everything on the system, but really one needs to preserve individual accountability whilst understanding the interplay between the person, the technology, and the organisation. Now, actions and failures of individual people usually play a central role, but their thinking and behaviour is strongly influenced and constrained by their immediate working environment and by wider organisational processes. And therefore, this organisational accidental model describes the immediate errors and problems and the background latent conditions. And so this is really an adaptation of Reason's model, particularly adapted to use in the healthcare setting, and classifies error-producing conditions and organisational factors in a single framework. And these 7 levels, so work environment, team factors, individual factors, task factors, and patient factors, as well as in the organisation and culture of the management decisions and organisational processes, really describe the contributory factors and influences on safety under these broad headings. And during the module in the classroom, we will be applying these to a particular incident to understand how we can use this in assessing and understanding better of how errors happen. So this helps us to look at something in retrospect once it's happened and understand a little bit more, so that we can consider how to, and improving things. So improving safety comes under 2 different approaches. One approach is to broadly to simplify, to standardize and improve basic processes. And these really reduce the reliance on people by automating or at least offering as much support as possible in those tasks in which people are necessary. And therefore, really, the kind of human contribution to the process of care is reduced to a minimum. And these kind of approaches are rooted in a basic industrial model in which solutions to errors and defects rest in increasing standardization, sometimes coupled with using technology. And includes a careful design of the basic processes of care and the appropriate use of technology. So, for example, computerized medication systems, to help overcome human fallibility or human vulnerability, particularly to fatigue and environmental stresses and influences. So the use of memory and decision support, for example. And of course, guidelines, checklists are a particularly good example of this. So with that kind of approach, here's just some key points, and I'm going to leave you with to consider in your own way. And if you want to look at this, please pause the video. The second aspect of the visions of safety is the understanding that, clinical staff really are simply doing their jobs well, actively, to create safety as we work. So at the coalface, minute by minute, safety either might be eroded by errors, and casual deviations from either procedure, or conversely, the opposite. Safety can be created really by skillful and safety-conscious professionals, and that's what the phrase "people create safety" really means. It's about being conscientious, disciplined, following rules in part, but also understanding that the treatment of complex, fluctuating conditions also requires us to think ahead, to be prepared, and really to be prepared to adjust treatment as the patient's condition changes. So not only are we anticipating the disease, but also, while we're functioning in the organisation that we work, we're assessing the hazards that might come from the change in disease, but also from the work environment. And therefore, safety from this kind of broad perspective requires anticipation, awareness of what the hazards are, preparedness, a degree of resilience, also flexibility to be able to change things and adapt things, and the quality that those studying high reliability organisations really have sought to capture and articulate. Have done that, and a couple of examples here. So Suzette Woodward, who is Director of Patient Safety, has a website looking at specifically how we can begin to improve safety culture. So thinking about how just moving away from how just one person does it, but how we do it as a team, and how we talk to each other, and what kind of relationships we have with each other, so that we can every action that we take and every decision that we make really is grounded in this kind of understanding around preparedness, resilience, flexibility, etc. And on the bottom there, I want to draw you to a particular resource, Learning from Excellence, and this is really about reversing some thinking around how we approach safety. So rather than just purely learning from things that have gone wrong, and then therefore trying to put things right for the future, an alternative is to look at how things have gone when they've gone really well, and just keep trying to do that again and learn from that instead. Well, or rather, as well as. So, within this context of people create safety, we can look at individual skill requirements. And here's a table from a piece of work done by some organizational psychologists who did a lot of interviews of physicians in general internal medicine in the United States, and they basically were able to identify what physicians thought were key skills and attributes of safe and effective clinicians. So there's 6 categories here, and I think it's worth reviewing this in a bit more detail yourself as an individual. And for me personally, one of my interpretations is that I've seen anaesthetists who are a great role model for anticipation and preparedness, and also vigilance. And I've also seen that experienced surgeons tend to anticipate difficulties and hurdles a little bit more than junior surgeons. So if we then, look at beyond just in our own individual skills, we know that as well as us individually and our attitudes, the way teams work that can either erode or create safety. And a team that is working poorly really kind of multiplies the possibility of error. And conversely, teams when working well have the possibility of being safer than any one individual. And here's a very good example of a tool or a method, huddles. Here's the reference for it from the Royal College of Paediatrics and Child Health, and a pilot study that they did in 2014, where 8 units tried to introduce a 10 to 15 minute multi-staff huddle before a ward round. And by creating additional defences against error, by monitoring and double checking and backing each other up, they showed that safety and psychological safety improved. And we know that there are checklists which help us overcome our human fallibility. Being aware that we need to, really ensure that everyone's understanding, including families and children, of what we're trying to do, why we're trying to do it, what could go wrong, or what we're looking for to tell us things might need to be different, needs to be shared. And one of the other tools that have been used, for example, in intensive care units, is the idea of daily goals. So deciding, what today's achievement or aims are going to be, and therefore, if we deviate from that, we can kind of step in and do something. And I think very much increasingly within the team, patients themselves and carers and parents are being increasingly recognised as an incredibly valuable member of the team with significant potential for improving safety. So, for example, there are hospitals in the United States where parents can actually put out the crash call without having to go through a nurse. And, all of this boils down to how we all get on and what our relationships are like in the end. So, having discussed how, people create safety as one aspect of improving it, and also standardizing systems and processes as another element, I want to move on to what we call the aftermath. And this is kind of unique experience as far as the patient goes, because patients and relatives can suffer in two distinct ways from a medically induced injury. First of all, obviously from the injury itself, and then secondly, really from how the incident is handled afterwards. So the emotional impact is particularly complex, because a medical injury really differs different from other accidents in some important aspects. Firstly, patients may have been harmed unintentionally by people in whom patients had placed considerable trust, and so their reaction may be especially powerful and hard for them to cope with. So, can you imagine what the complex of emotions we might have if we were accidentally injured by a member of our own family? And the full impact of some of these incidents really only become apparent in the longer term. So here are 9 points of practice to consider as healthcare professionals when dealing with adverse events or errors that have led to harm. And I will let you pause the video to really digest these and maybe think about how often have all of these actually happened in your own practice when dealing with these problems. And we know that, again, they're going to happen reasonably frequently. And it isn't just the patient who has this kind of unique experience. There's the concept of the second victim. human beings make frequent errors and misjudgments in every sphere of activity. It's worth realizing that some environments are less forgiving of errors than others, and the thing with medicine and clinical practice is that the consequences can be severe or even catastrophic. And so that's not really to say that the errors of doctors and nurses are perhaps more reprehensible, although, with the recent court cases and the GMC, that kind of makes one think differently. But only that the consequences of our errors bear a greater burden because of the greater consequences to patients. And so, making an error, particularly if a patient has been harmed because of it, may therefore have profound consequences for the staff involved. And particularly if, when we're involved, if either rightly or wrongly, we see that we're perhaps primarily responsible for the outcome. So support for staff is really key, and from what I've seen, this is really highly variable within organisations. And it makes me kind of ask the question, just how do I come to terms in the end with unintended harm or injury, which, although is unintended, is perhaps preventable. Something perhaps we might have time to discuss in the module itself. So I'm going to finish the presentation, really with summarising what we've covered, that we've looked at definition of error and mistake, an adverse event, looked at the scale of the problem between 10 and 15% of patients. We've had a brief review to understand how things may go wrong in using the adapted James Reason's model and the 7 factors that can be identified. We've thought a little bit about how to improve healthcare systems and processes, and be aware that also the second vision of safety, people create safety. And we've touched on the aftermath. So I just want to point out people in these photographs who are an inspiration to me. The top left is Professor Charles Vincent, who was formerly Professor of Clinical Safety Research at Imperial, at the Centre of Patient Safety and Service Quality. In the middle is Suzette Woodward, a former PICU nurse who's now Director of Patient Safety at the National Patient Safety Agency. That's a bit of a mouthful. And then Dr. Adrian Plunkett, who's a PICU consultant in Birmingham, who set up the Learning from Excellence movement. So I hope this has been stimulating. Thank you very much for listening, and I'm going to finish there. Bye for now.